Good evening, everybody, and welcome. Welcome to second webinar in a series of our educational meetings under the name OnkoKompas. So for new ones, just a couple of information about our concept. So OnkoKompas is a joint project between my long-standing partner from Austrian healthcare system, Premika Mavimed Private Clinics, and myself. And our idea with these webinars is to provide you, the broader audience, all interested parties, cancer patients and families, with practical guidelines and general support on the path of cancer treatment in a simple and understandable language for everyone. Our wish is really to provide clarity, because we know from experience that a cancer patient and his family, they have many unknowns, many fears, many question marks during the process. So our wish is really to give you high quality expert information. Why is this important? Well, because through better information, both of patients and of their families, at the end, we really arrive at better treatment outcomes. And I really emphasize this, and I repeat this all the time, but the right information is really the first line of therapy. So therefore, also we have a motto in our OnkoKompas webinars, and which is trusted knowledge leads to better outcomes. And this is really the truth. So for those who missed the first webinar and do not know me, just a short introduction about myself. My name is Maja Zakaria, and I'm a founder and managing director of Medhel Serbia. I am a certified facilitator and coordinator of medical treatments in foreign countries. My focus country is Austria. So I have been helping patients and their families to organize different medical treatments, especially in Vienna, for I think more than 10 years now. And during these 10 years, I really often heard the question, why Vienna, why Austria? I spoke about that in more details in first webinar, so I won't repeat myself. But I will say that actually, the main reason for my choice to be Austria is that really a healthcare system in Austria, especially in Vienna, it's not just a system. It's really more than a system. It's really a tradition of really high quality healthcare. And at least in teams with who I work with, it's a kind of a mission to try every single day to be better and to give better cancer care to patients and to their family. Vienna is also known, and Austria is also known for their medical expertise. Vienna is home to the largest medical organization in Austria, which is Medical University of Vienna, which is really one of the most important and top-level research institutions in Europe, in the world. Vienna itself is really a cancer, I can say, hub for cancer research and new developments in therapies. Medical University of Vienna is connected to Europe's largest hospital, AKH Vienna. Many of you probably heard about this hospital, so your General University Hospital in Vienna. It's placed among top medical institutions in the world. And it's not just the expertise, it's also devotion of teams, trust in my team members, their expertise, precision in diagnostic, in treatment, transparency. These are all just some of the reasons why I choose Austria and Vienna among all other destinations for medical treatments abroad. And to come to our today's topic, October, as you all know, is traditionally Breast Cancer Month. So this OnkoKompas episode will be dedicated to breast cancer. And today we will explore how modern breast cancer care is planned, how it's delivered, and we will focus today on surgery and medical therapy, because my experience showed actually that patients are entering their treatments without understanding what is actually happening and why are they undergoing certain treatments or not getting certain treatments. So therefore, my guests today are joining us from a Mavimed Comprehensive Cancer Center Vienna and from Private Clinic and Ambulatorium Döbling, which is both of the institutions and entities actually are part of Austria's Premika Med Hospital Group. I I will give you a couple of background informations why I choose these entities within the group. And the main reason is that within the Ambulatorium Döbling, there is a specialized cancer center dedicated to the treatment of female cancer, so in particular in treatment of breast cancer. And this center brings together at one spot all essential diagnostic services from one side and experienced interdisciplinary team of radiology, surgery, oncology, pathology experts, and also non-medical disciplines and complementary medicine. In the upcoming minutes in this evening, you will hear from my guests why this matters. So all of these people are working together through tumor boards, ensuring that really every treatment decision is made with a comprehensive view of the patient situation from all sides to get really a big picture. And they go even further. This is really something what I appreciate really much. They support patients through trained onco-nurses who provide patients both from medical sides and also from emotional care, which is often really totally missed or forgotten part of the treatment. Why am I emphasizing all this and this presence of specialized breast cancer center? This is something that not every hospital can offer. And why is this important for you as a patient? Well, because imagine the situation where you have a group of individuals, specialists, who are just focusing on their field and their specialty. Without seeing a big picture, patients in those kinds of situations usually, eventually, at some moment at the process, come to a problem. Because today, you need something else. You need integrated approach. And this integrated approach is actually what makes a breast cancer center at private clinic Döbling. This makes a difference in cancer care, really. So today, in today's oncology and cancer care setting, and especially in breast cancer, you need a team. And therefore, at this point, I would like to introduce my guests so that you actually know who are the experts that you are listening this evening and who will give you some advices and some inputs on cancer treatment, decision-making, important topics in planning of surgery, planning of medical therapy, and so on. So my first guest today is university professor, Dr. Christian Kainz, who will be covering surgical topics this evening. Professor Kainz is medical director of private clinic and Ambulatorium Döbling. He's a director of the Department of Obstetrics and Gynecology at Vienna International Healthcare Center and also chief medical advisor of the Premica Med Hospital Group, which actually treats more than, listen now, 130,000 outpatients and 52,000 inpatients each year. You will agree with me, this is really impressive number. And the CV of Professor Kainz is also impressive, so I will just take a liberty to read some points from his CV because it's really long to read everything. So his field of expertise is gynecologic oncology and surgery, as well as women's cancer prevention. He's an active member of several European and American professional societies, including the International Gynecologic Cancer Society and the Austrian Gynecologic Oncology Group. He also received numerous awards and fellowships and research awards for his contribution to cancer medicine, and he is also consulting expert for the Commission of the European Community for medical research projects. And my second guest is my dear university professor, Dr. Johannes Drach, the head of Cancer Center at Mavimed Private Clinics, specialist in internal medicine, in oncology and hematoonkology, also within Premica Med Hospital Group. You know Professor Drach already from our first OnkoKompas webinar, where he covered all critical points in cancer journey. Today, he will cover the part of medical therapy of breast cancer, which is, I can say, one of the most complicated areas because breast cancer, as he says, is not simply the breast cancer. You will have the opportunity to hear why is that. So Professor Kainz and Professor Drach, welcome, and thank you for taking the time to be with us this evening. If you agree, I will give you the word, Professor Kainz, to greet the audience and maybe to start with this topic for today from the perspective of surgery and diagnostic prior to surgery. And then Professor Drach, you will just also combine with Professor Kainz where you need it, where you think it's necessary. You have a word, Professor Kainz.
Okay, so to have an appropriate treatment of breast cancer and breast tumors, not all breast tumors are malignant tumors. It is very important to have a very good diagnostic workup before you do the treatment. So for the diagnostic workup, we have the clinical examination, we have ultrasound, we have mammography, and we have the MRI, the magnetic resonance imaging in our tools available. To evaluate the whole body situation, then we have also PET-CT, but this is not to focus on the tumor itself in the breast, it's more to focus on the spread of the tumor in the rest of the body. We provide in our institutions all these instruments, and we have specialists who take care of these breast tumors. So in most cases, the tumors are found by palpation or by the routine screening procedure. And then if they are suspicious or not clear, benign, we have to have further workup, which means we do an MRI in many cases. The MRI is done with contrast media. And in this examination, we can see if the lesion takes up a lot of the contrast media, which is a sign of malignancy, for example. We see the size of the tumor, and we see if the tumor is a single tumor or if it is a so-called multicentric tumor, because some of the breast cancer tumors are spread in one breast, and this is then called multicentric. All these examinations are necessary to go to the next step and to decide if you do a primary surgery or if you do a needle biopsy and take the histology before the further treatment steps. The histological biopsy has the advantage that we see if the tumor is very aggressive, if it is malignant or not malignant, if it is very aggressive, and which type of tumor it is, if it is hormone sensitive or not, and so on. In the next step, in the tumor board, there is the decision made if surgery or chemotherapy or systemic therapy or anti-hormonal therapy is the next step. And at some point, there will be then the surgical treatment. Yeah.
Okay, so for you, sorry, for you as a surgeon, because this is something which I noticed that the women's, our patients are not understanding well. They just think surgery is surgery. But this biology of the tumor and receptor status, how important is this for you as a surgeon to decide whether you operate or not? And I also received the question, is it surgery possible if in initial diagnosis you see that this is a metastatic cancer? Is this surgery still an option?
So surgery is always part of the treatment of breast cancer. There is almost no case where we do not do any surgery. The most important thing is to decide in which line you do the therapy, the systemic therapy, the surgery, and the radiotherapy. So surgery is always part of it. But in very advanced tumors or metastatic tumors, of course, in the first step, the systemic treatment, where Professor Drach is the specialist, is the first step in the treatment cascade, and surgery is later done. This has the advantage that through the systemic treatment, the tumor can shrink and you have an easier way to remove the tumor by surgical means.
Okay, may I introduce a question for Professor Drach? I used to hear very often from different specialists in Austria that Austria is, in terms of breast cancer, is a very neoadjuvant country. It means that you use very much neoadjuvant systemic therapy in Austria, comparing, for example, to our country. Can you explain us a little bit, Professor Drach, about this topic?
Yes, thank you very much for this important issue. And so I can really follow on the topic that Professor Kainz just has mentioned. So in Austria, we have been following a treatment strategy for a good time already now, that we frequently use medical treatment and chemotherapy first, prior to surgery, prior to the operation. And this describes the type of treatment that we call neoadjuvant treatment. Why is this done? Well, the strategy is we want to give chemotherapy, as mentioned, to get the tumor as small as possible, and thereby enable the surgeon to do effective therapy and resection of the tumor in a much easier way. And for the advantage of the patient, in many cases, a breast conserving approach can be taken. So in the old days, there was more or less just a decision, how big is the surgical intervention? And usually it was mastectomy in the majority of cases. But with the approach to shrink the tumor and then do surgery at a later stage, the concept of breast conserving surgery has been established, and this is now the setting in the majority of cases. So 70 to 80% of cases can be managed in this way. So it is more effective and even better for the patient to use such an approach.
Okay, and this is actually a very interesting topic, and I can continue and give a question for Professor Kainz. So regarding this operation and tumor size and everything, what we noticed here in our region is this tumor marking is something that is missing in almost 90%. This is one thing. And another thing is that women are very often asking for mastectomy by themselves. They're insisting on that out of fear, out of, I don't know, not enough information. So can you please maybe give some additional information of this partial surgery, and also of the importance of tumor marking before begin of the therapy and before the surgery?
As Professor Drach mentioned, the goal of our surgical treatment is so-called breast conserving therapy. That means we only remove the tumor itself or the residual tumor after systemic therapy with free margins. And it was shown in international studies with very big numbers that there is no higher risk if you do the breast conserving therapy. And of course, the breast conserving surgical treatment is less invasive for the patient, better for the psychological outcome of the patient, better for the whole immune system and so on, because it's not such a big trauma than the mastectomy. We have to do mastectomy nowadays in very rare selected cases. And if this is necessary, we normally do a primary reconstruction.
And are there cases where there is clear indication, okay, now we need to do mastectomy? Can you maybe give some examples?
Mastectomy is sometimes necessary if it's a multicentric tumor. That's what I mentioned in the introduction. That means that it's not one node in the breast, but there are many focuses of malignant tissue. And then it's the only way to have a safe treatment by removing the whole breast gland tissue, because there are many small foci and centers of malignancy there. So this is the main reason when we need mastectomy. Or in very big tumors which cannot be shrinked, but this is almost not the case because the systemic treatment improved a lot.
Okay, great. And regarding this marking of the tumor, this would be really nice if you could explain a little bit in detail, because as I said, here in our region is this really something which is not done. So, but it can be organized if somebody is informed that it's necessary. So if you can give maybe an input on this topic.
Yeah, this is very important to have a tailored treatment, that you remove the right part, that you remove the tumor and you remove it with free margins. You are right. It's important to prior mark the region. It starts when we do the first biopsy with the needle. We put a clip at the region. A clip means it's a very, very small metal clip, because that we know later where the biopsy was done. And also if the tumor shrinks or disappears totally, we find the area which we are interested to remove, because it's marked by this clip. For this, it's very important that we have a very good radiologist, because this marking is done by the radiologist. And it's the basis for a good surgical treatment later.
Okay. And for you, Professor Drach, as an oncologist, how important in this marking is, or is it important for you?
Oh, yes. Oh, yes, this is important. Let me also add something to this topic, because this is something I hear very frequently from patients. It is the concern that when we do biopsy and when we do marking and these interventions prior to treatment, that this may be harmful in a way, that this may contribute to early spread of the tumor. And this may also be the reason why these approaches with biopsy, medical treatment, and surgery to a later point is not so popular compared to the primary intervention by surgery, because it's in the mind of the patients. Well, I have surgery, then the tumor is out of the body, and there are not any interventions that may contribute to early tumor spreading. This has been investigated over years, and extremely high numbers of patients have been followed, and we do not have any evidence that by biopsy, marking, and all these interventions, that this may be of any harm to the patient, and this may have an effect on metastasis, or maybe that the tumor does not respond to treatment or whatever. So theoretically, this might be a fear, but in praxis, we do not have any evidence. And this is my strong message. Don't be afraid of this. There is no sign of any harm by this. And to know about the tumor is so important. We have so many different types of breast cancer, and the treatment approach is so different depending on the type. Therefore, this biopsy and characterizing the tumor is so important, and don't be afraid of any of these risks that are just theoretically. Coming back also to the marking, this is really important as an important help for the surgeon, because with modern treatment we can achieve a complete remission by this neoadjuvant treatment in a significant number of patients. Yeah, by characterizing the tumor and knowing exactly about the biological features of the tumor, we can design the treatment. We can use the right chemotherapy for each patient. We can combine it with immunotherapy, with an antibody, if indicated. This is in about 30% of cases. We will combine it with immunotherapy. We can also use an anti-hormonal approach if indicated. So again, a very individualized treatment, which leads to a high rate of complete regression of the tumor. And without a marking at the beginning, the surgeon will not find the place where to remove the residual area where the tumor was. Therefore, this is really an essential step for successful treatment by medical treatment followed by surgery.
Okay, and just to come shortly back on different types of breast cancer, because as I said, I received also questions from male patients. So maybe just to touch shortly male breast cancer, because almost nobody is speaking about that. For the audience, which is going to listen this afterwards, is breast cancer treated differently, or everything this what we are speaking about tonight is also considering male patients with breast cancer? Please, both of you, if you can just give a short input.
And maybe I can just start and mention, yes, there is also breast cancer in men. It's a rare disease, so no comparison about the frequency that we see in women. So it is about the incidence in Austria, and I think it's pretty much the same in your country. So it's about one new case in 200,000 men per year. This is it's really a rare condition. And as always in rare tumors, there are not many clinical studies, so clinical trials establishing what might be the best treatment. So therefore, the principal treatment approach in breast cancer in men is very similar to what we are doing in female breast cancer.
Okay.
And to comment on the surgical treatment, of course, it's the same principle to remove the tumor with free margins. But of course, the cosmetic situation is different in men than in women.
Okay, so regarding the reconstruction, it's not so complicated.
Yeah, but from the for the sentinel lymph node and everything else is the same principle.
Okay, continuing on sentinel node, because this is one of the most discussed topics today, how to treat axilla actually in breast cancer. What can you tell us about this? When it's really necessary to remove a complete axilla, and how do you make actually the decision? What is the sentinel node, and what are the most important informations there for a surgeon and actually for a patient to know?
So this was one of the most important developments in breast cancer treatment, was the treatment of the axillary lymph nodes, because at the beginning of surgical treatment, there was the goal to remove as many lymph nodes as possible, which resulted in severe problems after the surgery, lymph edema, pain, and things like this. And through very big numbers, very good studies, it has been shown that it's very safe to remove the so-called sentinel lymph node. What is the sentinel lymph node? The sentinel lymph node is the first lymph node which is in the draining lymph system for this breast and for the tumor. And the principle is to find this sentinel lymph node, to remove it, only one lymph node or two lymph nodes, and to do an examination of this lymph node. And we know now from very good studies and from very good data that if this lymph node is free of tumor, then we are sure that the other lymph nodes are also free of tumor, and it makes no sense to remove more lymph nodes. How do we find the lymph node? The lymph node is found by marking before removing the lymph node, of course, and there are in principle two ways. One is to inject blue dye in the breast tissue and to find the lymph node then by coloring it through the blue dye. And the other one is a nuclear medicine test where you inject a tracer, technetium tracer, and then have a probe which you put on the skin in the axilla and which shows you the location. And this has another advantage that you can do a very small incision just over the area where the sentinel lymph node is, and then find also the sentinel lymph node.
Okay, great. And okay, besides removing so less possible lymph nodes as possible, so what are the other ways to somehow minimize or reduce this risk of lymphedema after this axillary surgery? Because this is very often problem, at least here in our country.
So the first goal is to remove only 1 or 2 lymph nodes. Yeah. And the other thing is that you do a good surgical preparation. That means that you spare the nerves and the other vessels around the lymph nodes because they're important, and to make a preparation to the lymph nodes which is not causing damage to the surrounding tissue. So it's important to have a very accurate preparation, surgical preparation to the sentinel or to the lymph node. Yeah.
So actually it matters who is operating, I would say, like this, and how is operating.
That's right, yeah.
Okay, Professor Drach, would you add something on this topic of axillary lymph node situation?
I think many important aspects have been already mentioned. I think it is what we have discussed, so primary surgery or neoadjuvant treatment plus surgery, and now treatment of the axillary region. It is a very good example how progress is being made and how much progress for the benefit of the patient has been achieved. Because we want to be, of course, we want to design our treatment as effective as possible. But on the other hand, we want to be so we want to reduce our invasiveness. And this is part of the strategy in oncology, so in all areas, but it's also true for breast cancer, and this is the achievement over the past years and decades, yeah, that the invasiveness has been reduced, still with a very good efficacy, and the methods have been mentioned, and this is the good message. We can achieve very good results, but the treatment is less invasive compared to, let's say, 15 years ago.
Okay, so generally de-escalation in surgery and de-escalation also in systemic therapy in terms of sparing surgery, not avoiding mastectomy. And regarding reconstruction, Professor Kainz, so I know we have different techniques, different methods. Can you maybe tell us a little bit of advantage, disadvantage between reconstruction in front of the muscle, behind of the muscle? What is your preferred technique, or how do you decide what is the best option for a woman to do it in front of the muscle, behind of the muscle, and what are the advantages and disadvantages of both methods?
So we have different methods for reconstruction. If we do a breast conserving therapy, we don't need too much construction. We don't need implants or anything. So this is the main important thing is then to adapt the tissues in the appropriate layers and to have a perfect cosmetic result. If we need to reconstruct breast tissue, we do it in cooperation with plastic surgeons. And there are different approaches and methods possible. One is to put an implant. And as you mentioned, you can put the implant behind the muscle or in front of the muscle. Nowadays, we put most of the implants behind the muscle because then the skin, the breast skin is better supplied and it's easier to have a good shape of the breast. And what is also a development of recent years is that we have meshes. That means we have a form of artificial tissue that we can use to hold the implant in the right position, because this is an important thing, that the implant stays in the right position, especially when you have removed a lot of tissue in the breast. But there is also another important method to reconstruct the breast, which is a flap. Flap means that you move body tissue. In most cases, it's a muscle which is not so important. For example, from the back or from the abdomen, you make a preparation of this muscle, and then you rotate it in the position of the breast. And you bring in this technique, you bring the volume into the breast without using an artificial tissue. You only have your own body tissue inside, so you will not have an implant. You will have only your own tissue, which has some advantages, especially in very young women, where it has to stay for a very long time, and the flap has also the advantage that the supply of the skin and of the nipple and so on is very good. So there are different methods which have to be used individualized based on the situation of the patient, based on the necessity, what you have to remove, and what you can do best. Yeah.
Okay, and are there certain indications where you can, I don't know, you can do autologous, so with own tissue, and you cannot do something else, or who is deciding? Is doctor deciding, or you? What kind of reconstruction is the best one, or simple the patient comes and says, okay, I would like to have it, I don't know, in front of the muscle, behind the muscle, or with my own tissue? How is the procedure?
The procedure is that it's a decision made by the patient and the doctor in a discussion. The doctor can tell the patient the advantages and disadvantages of different methods. And then some patients have their own dislikes and likes, their own preferences. So some women say they don't want an implant. Then, of course, the flap is very good. The flap surgery takes longer. It's a little more complicated because you have to prepare this muscle. You have to make the vessels. You have to prepare on them and so on. But and some women say, okay, they want a simple method, a fast surgery, and then the implant is better. But the decision is made in a discussion and in a joint decision. So
the operation with its own tissue, so cosmetically seen, it's also nice and natural, like with the implant, because I hear for the first time for the flap, so therefore I assume that also girls from my region also don't hear it so often, because I'm pretty sure that nobody is doing it here in Serbia. So this with flap for young girls would have the same visual effect as implants.
Yeah, you can do with both methods. You can achieve similar cosmetic effects. Yeah.
Okay.
And as I said, flaps are a little more complicated. They are, and we do it in cooperation with plastic surgeons, because you have to do a flap surgery which takes 2 or 3 hours, and where you have to prepare, to make a preparation of the tissue, and
And how big scar remains on the abdomen?
The scar is bigger, yeah. But for cosmetic reasons, it's mostly done in most cases done with a flap from the back, so it's on your back. But the scar is about, I would say 10 centimeters. And then you remove it, you move it to the front side, and you keep the vessels that you have a good supply.
Okay, great, thank you. So, Professor Drach, now we are coming to the most hot topic, medical therapy. I have to tell you, I received over 20 questions regarding different issues of medical therapy in breast cancer. So you will explain the diversity of breast cancer as short as you can, because it's not so easy. And it would be great if you could clarify a little bit the difference between different drug groups for breast cancer in terms of immunotherapy, hormonal therapy. Here in Serbia, we have a name biological therapy, and I never know what they want to say. And of course, this new class of drugs, antibody drug conjugates. So you decide in which is going to go first. So I give you the word. Yeah.
So how long is the schedule for this program?
As long as we need it, and until you say I cannot anymore.
Because, so it's not, I'm not joking. It's just the topic is really very broad, and we can fill 2 evenings with that.
Yeah.
But let me get started with the issue that we have already touched at the discussion of the diagnosis. It is really so important to know the type of breast cancer present in an individual woman, and just to give let's say, a simplified view, and also to explain the class of agents in a medical treatment that we are using. Yeah. So there is a frequent finding is the so-called hormone receptor positive breast cancer. So when you read histology, the pathology report with histology and immunohistochemistry, then you will find this name of estrogen receptor or progesterone receptor, and this is related to the hormone receptors. Yeah, so this indicates that at least these hormones are driving the growth of the cancer cells, and therefore the therapeutic strategy is to use medicines that block these hormones, either at the cancer cells or in the body, that less of the hormones is being produced. And this is also important in the context, because when there is a history of breast cancer, in particular history of breast cancer with positive receptors, then there is absolute no way to use, for example, hormone replacement therapy when you get into this phase of this hormonal change during aging. Yeah, just to explain that this is all connected with that. So hormone receptor positive cases, that we have the chance to use various drugs to block receptors to reduce hormones. And this also in special situations, for example, together with other approaches. What do we mean with other approaches? There is the importance, of course, to use, still it's important to use chemotherapy at particular stages of the treatment, because chemotherapy is just the name of medications that interfere with cellular growth, with cellular proliferation, cell division. This is, of course, present in many cells in the body, not just the cancer cells, also the normal cells. They need to divide, they need to grow. Yeah, but the cancer cells are much more susceptible to these drugs used in chemotherapy, and their proliferation is changed. You may also see it in a pathology report. There is a specific marker that is being routinely evaluated. It's called Ki-67. It's a proliferation marker and tells you the amount or the fraction of cells that are actively growing, actively dividing. So usually when you have 10 or 20%, then it's considered to be rather low, and the tumor obviously is not so aggressive. But you may have tumors with a Ki-67 in the order of 50 or 60, 70%. So this indicates, well, a large amount of cells are actively dividing, so this will progress rapidly. But on the other hand, these are the tumors that are also susceptible to chemotherapy, because this is the target. So this is chemotherapy. What about immunotherapy and these approaches? Yeah, so this again leads me back to pathology and the evaluation of breast cancer. There is a particular gene with the name HER2, HER2. This has been discovered already many years ago. It's the name of a gene when it is overexpressed or it's amplified on the genetic basis. We call it amplification. Then this leads to a protein on the surface of the tumor cells, which is a receptor. And again, it's a receptor for a particular growth factor. So when there is this HER2 amplification, a genetic amplification present in the cancer cells, you have a particular feature on the outside of the tumor cells. And the tumor cells can, they can get signals from the outside that stimulates their growth. It's about present in 25 to 30% of cases. And usually these tumors, they are more aggressive. However, with the introduction of immunotherapy, with the introduction of antibody treatment, working just against this receptor on the cancer cells, we have an additional way of treating the cancer. And then now with combined immunotherapy and chemotherapy, actually the prognosis is getting much, much better, because we have a combination of medical treatments available to treat this very specific subtype of breast cancer. So immunotherapy in this case is the name for antibody treatment, and the antibody recognizes this very specific feature or this specific receptor on the outside of the tumor cells. And this medication can only work in these cases. Antibody treatment is very specific, and it goes only to this feature. It is like the key to your door at home. Only your key will work in this particular door. And this is like the feature on the cancer cell, and the antibody goes there. And the main mechanism is the antibody binds to the cancer cell and tells the immune system, here is an abnormal cell that we need to attack. Somehow the cancer cells were able to escape from the immunity, but with these medical antibodies, we can again bridge the tumor cell and the immune system, and activating the immune system against the cancer cell is an important mechanism. And this is also the reason why the combination of antibody plus chemotherapy is then so effective, because these are two completely different strategies attacking the cancer cells from different angles. And by adding the efficacy of both drugs, this makes the treatment really very effective.
You are speaking about this new generation of drugs like HER2.
So this was, I was mentioning just the antibody.
Just the
antibody, yeah, and combined with traditional chemotherapy. I just wanted to follow on what you have mentioned. Sorry. Yes, this is then the field of what we call antibody, so ADC, antibody drug conjugate. So this is a very also a very special formulation, because it is the combination of antibody labeled or antibody tagged with a chemotherapeutic drug. So the principle is we use the antibody as the transport vehicle, that the antibody binds to the cancer cell, and then the chemotherapeutic drug attached to the antibody is getting internalized. So it is a way that the chemotherapy goes only to the cancer cells, or predominantly to the cancer cells, and not to the normal ones. This is the limitation of classical, of conventional chemotherapy. It does not really distinguish between normal and cancer cell. But the antibody drug conjugate is now a step forward. We bring the chemotherapeutic drug just to the cancer cell. It's being internalized and has an effect on proliferation of just the cancer cells, and not the mucosa, not the blood cells, and also to a much lesser degree hair cells in the skin where hair growth takes place. This is ADC treatment, something that is being used in metastatic disease, and it's being explored now also much earlier, also in the adjuvant disease. So adjuvant treatment, this is the step where medication is being given immediately after surgery in a way to reduce the risk of disease recurrence. That is the adjuvant treatment phase, also very important. And ADCs are being explored in this setting, and I'm sure they will come to this phase of treatment in the near future. So we have covered hormonal therapy, chemotherapy, antibody, ADC, and then there is also some biological treatment. It is a way that we use a medication that has a target in the cancer cell, usually somehow related with the complex process of cellular growth, cellular proliferation. These are so-called CDK inhibitors. So this is not classical chemotherapy, but they have an effect, let's say, at the end of the day, it is similar to chemotherapy because it blocks cell growth. But it is in a different way. It's not in the nucleus of the cell that it is working. It is rather outside, blocking a particular pathway in the cancer cell. and therefore it blocks cellular proliferation different than conventional chemotherapy and has much less side effects. This is the importance. So biological treatment in this way means we use medication that interferes with critical points of cellular metabolism, leading to cell death at the very end, of course. This is what we want to achieve with all these strategies. But it is very specific, or much more specific than conventional chemotherapy, and thereby it is much better tolerated than conventional chemotherapy.
Okay.
So these are the major players that we have in the fight against breast cancer and also in the fight against the advanced breast cancer. And choice of drugs is really dependent on type of the disease, and then also, of course, depending on the stage of the disease. What I would also like to add is, so we need to characterize the disease at diagnosis. Despite all our progress, it may still happen that the disease comes back at some point in some cases, and we need to treat again, or the disease advances to some metastatic stages. But it's again important to characterize the disease again at such recurrence. When the disease comes back or it goes to other organs, it's important to characterize it again, because the disease may change over time. In particular, when we had receptors at the beginning, this does not automatically mean we have again a receptor positive disease at disease recurrence. So therefore, the characterization of the disease also at the time of recurrence is very important to define which drugs may work and which may not be good in this individual case.
Okay, if I may interrupt, we were speaking in the previous webinar about this molecular sequencing, EGS, and so on. Is there some recommendation in breast cancer? Is it useful to do some additional molecular analysis in the moment of diagnosis, or just first with the first relapse or recurrence?
So, yeah, there are molecular tests available. A rather complex or comprehensive analysis of genetic changes in the cancer cells. So they do not have a place at diagnosis, because we have talked about the relevant molecular features and the relevant characterization of the tumor cells, relevant in a way that there is a consequence for the treatment and the choice of medications. Of course, yeah, you can also type the tumor in a very comprehensive way at diagnosis, but it's a waste of money, because you will find abnormalities, but we do not have any medicine against it. So we know there might be a gene XYZ that is in a altered way, in an aberrant way, but we cannot use this information in terms of designing a specific therapy because of that. Even at first relapse, it may not make a difference, because the situation is pretty much the same. There may be a use of such comprehensive molecular platforms in very advanced cases, when we have used many or all of our medications that we usually apply to treat breast cancer, and then the disease is still active. Then you may find something by such comprehensive tests to use any abnormality. Again, the probability is not high that it will happen, but if there is a place, then at the advanced stages, to find a molecular aberration that might be used with a medication that we know from other cancer types that could then have an effect.
Okay, thank you. And we agreed that we are going to address this hormonal therapy together with you and Professor Kainz, because we received also many questions. So general bones and hormonal therapy. How can we protect bones when we are taking hormonal therapy? After how long there is a possibility that the resistance to hormonal therapy is going to develop? I also received one question. if the combination of hormonal therapy, femosol, and anti-epileptic drugs have some side effects, and if so, which ones? So maybe if you can give a joint overview of new approaches or important approaches regarding hormonal therapy in breast cancer.
So as you heard, and the therapy of breast cancer is now a very individual and personalized therapy. In former years, every woman got the same therapy, and the big difference is that now we characterize the tumor and then give the treatment the woman needs, and avoid the treatment the woman does not need, and therefore the side effects are less. And there are tumors, they are hormone dependent, and in these tumors, the anti-hormonal therapy is very effective because it blocks the actions of hormones on the tumor tissue and also on the rest of the breast tissue, and avoids and reduces the chance of recurrence or a new tumor very, very much. In principle, there are two different approaches. One is the so-called SERM. SERM stands for selective receptor modulators. That means these substances act in the breast tissue as an anti-estrogen, and in other tissues like the bone tissue, and therefore I come to this issue, it acts like an estrogen, and we know that estrogens are very good for the bone density and for the strength of the bones. So if we use selective estrogen receptor modulators, we don't have to be afraid about the bones because they are good for the bones. Some substances in this group are the most well-known is the tamoxifen, for example. We use this in premenopausal women, and these substances have no problem for the bones. Another substance which are used are they are blocking the production of estrogen, and for these substances, it's like letrozole or similar substances. It's right that the bones are more in danger because it reduces the total estrogen production. So we have to be careful with the bones. We have to monitor the bone density. We can have preventive measures like enough vitamin D, enough calcium, and so on. But if we need some, if we get in a problem with the bone density, we either can switch to the other ones, the SERMs, which are also very effective, or we do treatments with new antibodies, and these new antibodies block the osteoclasts and they increase the bone density. And we know a side effect of these drugs that they are also good for the prevention of breast cancer. So these are the different strategies to prevent the bones, and we have no problem in general with the bones in combination with the anti-hormonal treatment.
Okay. And regarding
just add
a
minor thing, but I think it is important. Professor Kainz has provided you with an excellent overview of this topic. But when you use letrozole or this class of agents, there is an increased risk of developing osteoporosis, and we use early on medications to counteract or to work against that. Calcium supplementation, vitamin D supplementation, and please use vitamin D together also with vitamin K2. So D3 plus K2, because this is today what we know the most effective way that the calcium that is being absorbed under the influence of vitamin D then also really gets to the bones and not to other places like the blood vessels. And we need the calcium in the bone and not in the blood vessels. So use D3 plus K2. This is an important, I think, an important message.
Okay, and is there a general recommendations about doses, or is it individual based on the laboratory findings?
It's an individual dose, because
Important to say.
yeah, it's important. You can measure it. The serum level of vitamin D3 can be measured. It's a simple analysis from the blood that is being taken also for other reasons. Yeah, and then you know your individual level, and then you also can derive the dose from that. What would be a good strategy to supplement, and you want to bring it up. Yeah, at a good therapeutic level, but it's individual depending on your starting point and where you are, and how you live, how much exposure outside do you get, and so on. So there is no, as also in other cases, there is no one size fits all. It's really individual. So this is a general topic we are discussing in oncology.
Okay, Professor Kainz, you mentioned tamoxifen. I also received the question for how long should tamoxifen be taken and what are the side effects of this therapy, if you can say something more about that.
So tamoxifen has as a side effect that it elevates a little the risk for endometrial cancer, but this is a real very low risk increase and has it in the but the benefit of the tamoxifen is much higher than this small risk increase. So there's no reason to have any fear about this endometrial cancer, but you will read it somewhere. That's the reason why I mention it. You have a little higher risk for thrombosis, but this is also not relevant. Yeah, for the patients themselves, they tolerate it very well. If they are premenopausal, they get their normal menstruation in almost all cases, also when they take tamoxifen, and normally they feel very good, yeah, with tamoxifen. It's a very well examined drug and well-established drug, which is very safe and has a very high impact on reducing the risk of recurrent or new breast cancer, for example, in the opposite side of the breast.
Okay, and we also received a question regarding changing or combining hormonal therapy with inhibitors. Is this possible to do, and can it help? I think in metastatic setting, I'm not sure, the question is a little bit strange.
No, this is, yeah, it is related to the metastatic disease. Okay. Or predominantly metastatic disease in hormone receptor positive breast cancer, and combining an anti-hormonal strategy with this biological therapy that I mentioned earlier. So these new class of agents blocking cellular proliferation at a different level compared to conventional chemotherapy. So that is now an established treatment concept in this specific type of hormone receptor positive disease, and in a metastatic setting, this is a very effective strategy, with the advantage that many drugs used with an anti-hormonal strategy are pills, so an oral drug formulation, and also this biological therapy, this anti-proliferative drug, is an oral formulation. So this is very convenient for the patient because it's fully ambulatory, and you do not need long stays in the hospital for infusions with all the hassles of that.
Okay. Yeah. And regarding metastatic cancer, I have just two more questions, and maybe I will read it and you will see if you can answer or not. So it says, how long can hormonal therapy with letrozole, famosol, be used for metastatic cancer? And can hormone receptor positive breast cancer mutate into triple negative? I think we spoke about that. So the answer is yes. So maybe you answer the first question.
Yeah, so the second part is already, we mentioned that. So it may change over time. Yes, therefore re-evaluation of the features is so important. And the duration in particular in the metastatic setting is as long as there is a benefit of the treatment, you should take it. And the benefit is defined as number one, it controls the disease, and number two, you have a good tolerance of the treatment. Yeah, and with both factors being answered with yes, then you should continue.
Okay.
And in the adjuvant setting, meaning in the tumor-free setting where you use the anti-hormonal therapy only to avoid recurrence, you use it nowadays a minimum 7 years. Yeah.
Okay. Okay,
Yeah.
thank you so much. I'm checking the questions because Professor Kainz, we actually covered a lot of surgical questions related to surgery. I'm just checking if we didn't miss something. I have one question regarding physiotherapy after the surgery. So how soon after surgery should physiotherapy begin? And can early rehabilitation reduce the risk of chronic pain and lymphedema?
Yes, physiotherapy is a very important treatment after surgery. You can start the physiotherapy 2 days after the surgery, and the goal of the physiotherapy is to have to avoid lymphedema, which is nowadays not so important because we never see a lymphedema when we only remove one lymph node. But also to avoid that the axilla and the arm gets in pain when you move it. So we have different physiotherapy options for this, and it's important. And you can start very early.
Okay, okay, thank you so much. So I'm going through the questions. So the next one would be how to treat brain metastasis. Primary tumor is breast cancer. How to treat brain metastasis other than gamma knife?
Well, so gamma knife is a very specific intervention, and usually it is being used when the metastasis in the brain is small. So small, and also on the other hand, there is a limitation in its use because related to the number of metastases. So usually it is being used with one or just limited number of small lesions. Then you can use gamma knife. The other approach is just conventional radiotherapy to treat metastasis to the brain. These are the two methods. And usually this indicates that the disease is in a metastatic, it indicates the disease is in a metastatic stage, and then also systemic treatment will be needed. But specifically for the brain, there needs one of these forms of radiotherapy or stereotactic treatment because the medical treatment usually does not reach the brain at the effective concentrations due to the blood-brain barrier.
Okay, thank you. Professor Kainz, I think this is a question for you. Low-risk ductal carcinoma in situ. Is tamoxifen only management after surgery an accepted option? This was the question.
Yeah, this is a good question.
Okay.
Like we discussed today, breast cancer treatment is now personalized, individualized. And in carcinoma in situ, where the tumor has hormone receptors, it's the right treatment, adjuvant treatment. Yeah.
Okay.
Tamoxifen alone, for example, or letrozole alone. But this depends very much on the molecular results done in the tumor tissue. For example, if it is expressing HER2/neu and it has no, then tamoxifen alone is not the only treatment possibility. But most of the carcinomas in situ have hormone receptors, and then it's the most often used treatment.
Okay, thank you. Professor Drach, we spoke a little bit about bone metastasis. So the question is, what are the therapy options for breast cancer with bone metastasis? I mean, we hear now the biology of the tumor actually dictates the therapy, but if you will or can say something more about this, if not, we're going to go to next question.
No, there is also, so of course, part of it is the systemic treatment of the disease, but we have medication also to protect the bones, or in other words, to reduce the activity of the osteoclasts. So this specific type of cells in the bone that are responsible for reduction of bone density. And osteoclast inhibitors, there are basically two medications. There is the zoledronic acid. It's something that we know for more than 20 years. It's an IV, so intravenous drug being administered once a month, in addition to the other medication to treat breast cancer. And there is a newer one, the denosumab. It's a subcutaneous injection also known under the name of Xgeva. It's a little bit more effective than the zoledronic acid, and again, reduces the activity of the osteoclast, and thereby it is a good strategy to use one of these medications to, in the case of bone metastasis, to treat the bone, to reduce pain, and also to have an additional factor to the systemic treatment.
And just to add, in single bone metastasis, radiotherapy is also a treatment option, especially against the pain, combined with the treatment Professor Drach mentioned.
Absolutely, absolutely correct. Yes, yes.
Okay, thank you. And we were mentioning resistance to hormonal therapy, and now I see here the question, how to recognize that resistance to a given therapy actually appeared and it's not working as it should be. How doctors are recognizing that resistance developed?
Well, this may apply to hormonal therapy, but also to the other types of treatment. This is the reason why you do some regular check-up tests, usually CT or any whatever type of check-up, to monitor your effect of the intervention, what you are doing. And when you see that the disease progresses despite a specific treatment, then it's an indication, well, this medication does not work anymore. It's another word for that the resistance develops, and you need to change the medication or change the general approach of treatment.
Okay, understand. Professor Kainz, is perimenopause a period of increased risk for developing breast cancer, and why? And does hormone replacement therapy influence that risk? This is a question. I think this is maybe your field.
Yeah. So the age where most breast cancers occur is around 60 to 70 years of age. So breast cancer is most often seen in older women. We have a different group of breast cancers who occur in younger age groups, but most of these breast cancers have a genetic background. So it's not typical the perimenopausal age for developing breast cancer. The most common breast cancers are seen in older women, or the genetic ones in younger women around their 40s. Hormonal therapy, hormonal replacement therapy, was examined in the year around 2000 by the World Health Initiative study. It was a very big study, and the result shows an increase in the risk of breast cancer. Nowadays, we know that this study had a very poor design, and the hormone replacement therapy used in this study population was not comparable with a modern hormone replacement therapy we do nowadays. Nowadays, we use very often the so-called bioidentical hormones for hormone replacement. And studies show that you use these drugs, these hormones, which are identical to the normal hormones which are occurring in the female body or which are circulating in the female body, then you have almost no or very, very small increase of breast cancer. And if you use only estrogen and not a combined estrogen-progesterone therapy for hormone replacement, you don't have any risk evaluation at all. So nowadays, a woman who needs hormone replacement therapy should use it and should not be afraid about the risk of breast cancer, because this risk is so small if there is appropriate hormone replacement therapy given.
Okay, thank you so much.
It's a very, very important information. Yeah.
Would you add something?
No, it has been very well explained, and it's just I just want to re-emphasize the importance of this issue. Yeah, because when there is such a big study and the results of such a study may have a long-lasting impact, but one needs to point out that there were particular weaknesses of this study, thereby the conclusion cannot be held anymore. And this is the important thing, and that it's so important for women that they can receive hormonal replacement therapy as we do it now, and as it is modern approach, and that this old strategy and these old data do not apply anymore. One of the key messages.
Okay, thank you. And Professor Drach, also one specific question for you. It's about one mutation, ESR1 mutation. What does it mean exactly if I have this mutation, and what can I do in this case in terms of therapy?
Yeah, it is. It's also a very specific genetic alteration. It's a recently discovered abnormality in breast cancer. Well, it's being studied. It's being studied even in more detail. Currently, we use the treatment that we have outlined before. Depending on all the features. Specific types of medications may be developed in this subtype of breast cancer, but at the moment, it's just under active investigation what it means and what can be done specifically for these women. It's definitely true that that there is growing data that by this mutation there is another. It's again a subtype of breast cancer that is being defined, but the optimal way of treatment still needs to be investigated in detail.
Okay, thank you. Good. So I think with this question, we covered almost all questions that we can cover in this format. I'm just checking in the chat. I saw some questions, but I think these are too specific, and I think we cannot answer this right now. But I will get back to this person after the webinar. For the end, I would like to do a small recapitulation. I mean, we obviously see the differences in outcomes in therapies between systems. So I would just like if both of you can, from your point of view, give the most important things in Austrian system, in this breast cancer center in Dublin. What are the key advantages in surgical terms, in terms of systemic therapy, and with a focus on this standard in Austria?
Who wants to start?
You choose.
I start. For me, the most important thing is the individualized therapy approach, the personalized treatment. The thing, like in former years or decades, one therapy fits all is not true anymore. And so it's very, very important to find the characterization of the patient, of the tumor of the patient, of the needs of the patient, and this will optimize the treatment. And that's our goal in our center, to have experts from all fields, oncologists, radiologists, plastic surgeons, all we mentioned today, to have an individualized treatment for the special needs of each individual treatment, because breast cancer can be very easy to treat with 100% cure, to very complicated cases, metastatic cases, where you need the whole treatment options of many of them. And I think this is the main important thing in our treatment strategy.
Okay, and for the patient?
Absolutely. But let me add one important thing that we have not yet covered in our discussion. And this is also the advantage of such centers. They also offer the opportunity for screening and early detection. Yes. I think this is a very important message that we should also spread. We have good tools with screening, mammography and sonography, and clinical examination of the patients for early detection. And this is the key for successful treatment and cure. And don't be afraid to do these investigations, because these really save lives. And it has been shown in so many studies that screening and early detection has such an impact on survival and on mortality from breast cancer, so that we can really avoid the diagnosis at an advanced stage by doing these interventions early.
And can you mention then, when we are talking about screening, can you mention this topic regarding dense breasts and mammography? Because Some women are talking about that dense breasts are not so good, mammography not so good for the breast which has a really dense tissue, that maybe ultrasound or MRI should be the better option. Can you maybe just touch this topic to have it covered as well?
So for a normal risk population, screening recommendation is to start with mammography. And depending on the density of the breast, to add ultrasound to mammography or not. There's no screening strategy for the general population only with ultrasound, because this does not work, because ultrasound can add to the mammography and it can be used to follow up fibroadenomas, but it's not used for screening. And the MRI, the magnetic resonance imaging, it has its place in special population, like high-risk population, like follow-up after breast cancer and so on. It's not a recommended screening tool for a general population. The dense breast you examine with mammography in combination with ultrasound.
Okay, thank you. And previously, I wanted to ask you, Professor Kainz, for patients who are actually searching a surgery abroad, what they should know, what they should take care about, because there are many of patients thinking about if they go to surgery abroad or not. So what is important in this situation to think about? How can they recognize a good surgeon? Let's say like this, if you have some tips.
This is a difficult question.
I know.
I think they should ask about the results the surgeon had and how his approach is. But otherwise, it's very difficult. Yeah.
It's difficult. And
I think I'm not from the surgery the team, yeah. But I think, as we have already discussed earlier, that you seek advice and help from a center where a team of experts is working, yeah. And the surgeon is part of this expert team. This is always a good sign. Let me rephrase it in this way, yeah. So then here I am in a surrounding. Here I'm in an environment where decisions and treatments are being done on a frequent basis. And when you do things very frequently, then you will be good at it. Yeah.
But it's an important issue what Professor Drach said. The surgeon should at least be embedded in a team of different specializations, from oncologists, radiotherapists, radiologists, because the surgeon alone cannot provide the best treatment. Yeah.
Okay, and maybe Professor Drach, just to recapitulate the things important regarding second opinion in terms of breast cancer. I think we didn't mention anything regarding this topic this evening, just as a closure.
Yes, second opinion is also a frequently asked question, and I would encourage patients to seek a second opinion. It is not a way that you do not trust what you get, but four eyes see more than just two eyes. Yeah, and it is a good advice before you go to undergo a complex set of treatment, to hear the opinion from a different expert in a way to review it. We have discussed there are so many aspects that need to be considered: type of the disease, individual approaches, individual features of a patient. Yeah, someone from a different expert team should have a review of the findings, and then you also get the confidence. All right, everything has been considered, and I'm in good hands for the upcoming months for the treatment. I think this is a very important way to get confidence in the treatment that I'm receiving.
Okay, and both of you are seeing actually many international patients on daily basis, and your personal experience in how many percent, let's say like this, you see change of the concept comparing to the concept of the therapy from the country of origin, if you can say something on this.
Well, I cannot give you any number or percentage or whatever, but what I just would like to emphasize is that this is what we are doing when there is a second opinion from an international patient. We routinely do, as part of this, re-evaluation of the histology and all the important molecular features, all these disease features we have discussed today, because this is so important for the whole process of treatment, that the right decision is being done right away. Yeah, and sometimes we observe, it has been done, but obviously the experience of the investigators was not the optimum, let's say, and we come up with some additional information by re-evaluating the biopsy, which makes a difference for the treatment. That is really something that we observe. And therefore, I'm mentioning it. This is an important part of the second opinion and the second evaluation. That again, the comprehensive view is being done, and you get on the right path right from the beginning.
Okay, thank you so much. I would say we covered everything. Professor Kainz, I don't know if you would like to close with something or to sum up with something. I don't have any questions now. I don't see any questions in chat. I will just ask shortly. If anyone wants to ask something, it can be, question can be made in Serbian language. Just to raise the hand. But I think, yes, if not, I would say thank you, both of you, for your time, for being here today. Yeah, just keep taking care about your health, ladies. Take preventive screenings and take second medical opinion from time to time. Check the biology of the tumor if you are in the process of active treatment. And all of us, we are at disposal. Contact data of Professor Kainz, of Professor Drach, of myself, and Private Clinic Dublin. We're going to stay under this video in all contact details. So if you're not sure, if you need consultation, we are here, all of us. So from my side, have a nice evening, rest of the evening, and then until the next time. And thank you so much, everybody.
Thank you very much.
Thank you very much.
Congratulations to
Thank
this perfect format of knowledge transfer.
Thank you so much for being part of it. Thank you and goodbye.
Good evening to everybody.
Good evening, goodbye.